Good morning, everyone, and welcome to our monthly live broadcast for peripheral cases from Mount Sinai Hospital, New York City. Today, June 20th, it's almost 8:06 Eastern Standard Time. We will welcome you to our next live case. Before I let the case be transmitted from the lab, just wanted to thank you all who participated in our Link Mount Sinai session. For the people who unfortunately missed it for any reasons, you'll be able to watch our cases on our website down the week once they get uploaded on ccclivecases.org. And of course, any of our previous live broadcast cases can be found in the archive section. Please do go in, log in, watch our cases, comments, concerns, questions, let us know, and we'll be more than happy to interact. So without further ado, we'll say good morning to PK. PK?
Hey, Vishal, how are you? So we've got a really challenging anatomy here. We have a wonderful patient here who has an ulcer of the foot with a lot of pain, who basically has a blockage in his iliac artery that's been ongoing for quite some time. So I'm going to go ahead and present our team first. We have Ray Lascano on this side, who everyone knows has been with us for every single one of our webcasts. We've got Sandeep Singla, who's our interventional endovascular fellow. We've got our wonderful AV team. We've got Elizabeth and Damien, our nurse here, and our technician. We've got a patient here who's really been suffering with significant peripheral vascular disease, and has developed a very, very painful ulcer in his foot on the left side. Unfortunately, he has not been given many options in terms of healing the ulcer. Though they've been trying to heal the ulcer, he hasn't been doing well. And he's even at rest with heavy sedation. He's having a lot of pain in that foot, and he moves it involuntarily because of the pain. So now I'm going to just go ahead and present the history to you. Can you put up the history side? It's a 64-year-old male with a history of hypertension, about a pack and a half per day smoker. Well, obviously he's trying to quit. It's tough to do. He's got coronary artery disease, status post PCI. He's got a remote CVA with residual paralysis. And he's really got a very painful ulcer on his fourth toe with rest pain. Physical examination-wise, nothing significant other than the fact that he has monophasic Doppler signals, and he has got some swelling, basically because of edema on the foot. So this guy, he's a gentleman who basically had a ABI that was done 0.42 on the left, and he's got low velocities on his SFA. So we have prior workup from before, which I don't know whether you put the angiograms in the presentation. Okay, so I can show you. So we did a diagnostic angiogram in the past, and he basically had and I'll show it to you once we get access, occlusion of his left common iliac with a thrombotic lesion, patent right lower extremity symptom, lower extremity anatomy, including SFA, profunda, and tibial vessels. On the left side, he's got an occluded left common iliac into the external with a little short nub, which I'll show you here. That I think we have a picture of. Right. I guess we didn't do an aortogram yet? Okay. Yeah. So we'll do an aortogram right now. So as Sandeep is just getting access here on the right radial in order to facilitate this, we're just going to do an aortogram here. So here's the aortogram. So you can see he's got an occluded right iliac all the way down into the right common or external iliac. And he's got bilateral disease on the right, which again will tell you why he's having the ulcer. You can see that he has a tight right-sided common iliac lesion as well.
Correct.
So at this stage, the issue is going to be, getting into this vessel and then going ahead and doing it. So what we're planning on doing is demonstrating, so our plan is going to be to have a pigtail at the distal aorta from above. We're gonna get retrograde access angiographically into the common femoral. If not, we'll do it with the sonogram. And then the sonogram is here, guys. The ultrasound. Can you bring the ultrasound in the room, Damien, and turn it on with the sonogram? And then what we're gonna do is we're gonna go ahead and do the intervention. And then once we cross, I guess we'll deal with that. So that's going to be our access. And I think it's important here, Vishal, to really talk about access points for the patient, because the patient knows what's going on in terms of the ulcer. He's been suffering from it from quite some time, and has not had many options given to him. Luckily, we have a normal creatinine, and we have a patient who's very compliant, has been following up with the podiatrist. So
Right.
before we go up with our sheet on the pigtail into the radial, what I'm going to do is just demonstrate access here.
I think it's a great point you bring up, especially with the accesses in these iliac CTO patients, because the pulse is barely palpable. So it's very hard. People think because it's a normal CFA or looking normal CFA that you'll be
A
easily
little
be able
pinch,
to
my
get
friend.
access.
Hang in there.
But in
Just hang
these
in there.
cases, it's very
You
hard to
feel it?
get an
Tell me.
access. Specifically, we don't have a pulse. So you're right. Probably an ultrasound or even like you're doing a fluoroscopy guided access. Maybe do it under roadmap, injecting from the top
right.
and trying
I'm
to
so
see
sorry,
if you get
sir.
a CFA. I think that'll be a great idea to do as well under under roadmap if you can see the CFA
Feel
from
that?
above.
So I know we're going to feel a little burning. I apologize, sir. It's just the needle going into the leg at this stage. So this is the hard part here. So what we can do is go to multiple views to see whether we're on top of it or on the side of it, which we may be. So sometimes it's worthwhile to take a picture. Ready?
Yeah, you want to do a roadmap PK and
No, roadmap doesn't help here because the filling is very poor.
Right, but
So the roadmap's not going to help. So here what you're going to do is you're going to kind of see where you are. You can see it's such a diseased vessel.
yeah. And
So what we're going to do here is just try to come back slowly, and that's the reason why he's not been, treated successfully in terms of his interventions. Roadmap, the problem is, he's in so much pain, he's going to move.
Oh, okay.
And I think that's going to spoil. Put me on corner, please. And I think that's going to not allow you to get it. So one of the things you can do a lot of times is you can look for calcium, and then based on the calcium, you can try to enter here. I'm sorry, sir. Hang in there. A little diarrhea. And you can see there, he's suffering so
right
much
over it,
because of the pain. The thing here, Vishal, is we've been in this vessel once already, and part of that is that it's just so diseased.
Right, the scar tissue. The scar tissue itself can be a hindrance. It probably deflects you off the vessel rather than entering the vessel right there.
So a lot of times here, what we may do now is just go ahead, flush this out, and just do an SFA stick, because the SFA stick is actually easier for us to get. So what I'm going to do is give him a little more numbing medicine. I'm just going to go down into the SFA, this area right here, and just do a distal SFA stick, which will help him, which won't be as painful for him because it's not in the groin, and will definitely help us to get in, and we can just hold pressure. Can I have a needle? And we can just hold pressure. So what we're going to do here is we're going to go ahead, give him a little numbing medicine. Sir, again, a little pinch. I apologize ahead of time, sir. A little pinch right there. Oops, sorry, a little wet. That's just the medicine.
And the only reason we're getting an SFA stick is because we know that the SFA is not that bad of a disease from previous angio.
I'm going to do a DSA picture here
Okay.
to show you guys. He's going to move a little bit, but that's normal because of his pain. So everybody can see the SFA. You see the SFA, guys?
Yeah, right.
So now I know where the SFA is, and I'm just going to try to go right over on top of it. The trick to these accesses angiographically is you definitely want to be parallel to the vessel in the AP view. So Ray's going to go AP here for me. Okay. Now I'm going to do another DSA. Ready? So that's the trick. Inject. Okay, so in the AP view, you want to be parallel, right? So, it's just a venous. That's just all different things. So in the AP view, I'm just going to go ahead. I see that little calcium speck is going to be my target point. So I'm going to go right here, right around there.
There.
Right? And then I'm just going to go straight down. Okay. And now I'm going to have Ray give me a little dye.
I guess Sandeep has to look around to see for that trickle or bleed because
Okay,
you're
now
right
what I'm going to
underneath
do is go oblique now. Go oblique, Ray. Okay, a little more. Okay, now I'm going to go ahead and give dye. It's a very important skill to have, you know.
Right on top of it. There, yes.
And maybe, maybe not. Looks like there's a trickle
Yes.
because he's got a very poor flow. Can I have a wire, please? So what we're going to do is we're just going to try to see where we are. Generally, you're mostly through and through rather than not. So in our experience, we've found that in these kind of situations, you want to try to limit. That looks like the vein. Looks like we went on the side into the vein,
Yeah.
as you can see. So we're just going to try to just pull back slightly. It looks like the vein again. Let's just take another picture, right? And sometimes it's always good to leave the wire in. You know what I mean? Don't worry about that. Leave the wire in this situation. This way you understand the relationship of the vein and the artery. And this is the advantage of the ultrasound versus not. See how I'm on the side of it?
Yep.
Which is very good to know. So now we're going to leave that wire in, right? So I'm going to walk this out. I'm going to let Ray flush this. And then I'm going to get arterial axis just next to it. Is he okay, Liz? He's I'm thinking a lot of pain. Hang on, sir. We'll give you more medicine. Hang on.
Yeah, I think it's a great teaching, learning point for people who are trying to get it under fluoroscopy. Is like leave the wire in. It's a micropuncture wire, like you said. So
Yep.
and it's in the vein. So you just hold pressure at
Give me
the end,
another
or
wire.
even right now, and it'll be fine.
Now remember, don't get frustrated if you keep hitting the vein. It's happened to us multiple times, but this looks a little more arterial to me. I don't know about how. We hit the vein again. Look at that. 2 in the vein. 2 for 2. You know?
It's
Isn't that
always.
amazing?
Yeah, I think the issue probably might be the vein might be just overlapping the artery right now.
Exactly.
So it's right one on top of each other. So that's why you might keep hitting the vein even though you keep moving laterally.
Right. So what we're going to do is we're just going to go up top above
Yes.
this.
Yes.
And then we're just going to go ahead and leave both wires in. Give me a little dye, Ray. Okay, I'm going to start right here. And you can see right here. So probably come in a little bit more medially, medial access. And try to go right in. If not, we're going to switch to ultrasound. And a little dye, Ray. Go lateral now.
I
Ray?
would go to the lateral there, right there.
Go lateral, Ray. Okay. Now I'm okay. Good. Now take a picture. Let's take a picture now, Ray. And see, Vishal's absolutely right. The vein is right on top of the artery.
Right, so you'll keep hitting
So
it.
I'm going to go a little bit lower, like right here. A little dye, Ray. Hang on, my friend. I apologize. Through and through. Ready, Ray? It's vein again. DSA? Let's see, it's vein again. Looks
So I
like
think-
we're going to try with ultrasound or go up top now.
Yeah, I think I would, if you want to, I would probably go up top because you already have a wire in the common femoral vein. You could probably try to see if you can get the CFA axis next to it. Otherwise, ultrasound is
another
the
wire?
best bet.
So we'll try a third wire here. We definitely have flow, but it looks like the vein. And again, we're in the vein. I'm going to keep just pulling back a little bit. Nope, we're in the vein again.
And I
I'm gonna
think
leave
it's
3
just
wires in the vein.
The vessel overlap is what's
Yeah, that's
causing
the
all
problem
the
here. Here, flush this out. So I'm going to go up top to the common femoral because now we know where the vein is and where the artery is.
Correct, right.
And then we're going to do access. Normally it's not this difficult. I guess with this gentleman, because of the disease and the edema and the concomitant vascular disease, he has a lot of, what is it called, overlap, lower ray. So let's start here.
So around that 30 marker and then.
Okay, DSA ray. Ready, inject. See how diseased that is, Vishal?
Yes.
That's why I wanted to go below.
Your profunda is bigger
Yeah,
than
I
the
think
common femoral.
I think I still want to go below. I'm going to try to go a little bit below right here. Okay.
Yeah, I think that's a better
Yep,
spot.
give me a little dye. Damien, more contrast, please. Hang on, my friend.
I think Sandeep should pull out the ultrasound if this doesn't work.
Where did you feel that, sir? Right in the top. We'll give you more medicine. So we were expecting this kind of problem to occur. Give me a wire ray. Actually, I'll use one of these. You have the same thing you're feeling in the leg? I apologize. Hang in there. I know.
Oh, it's probably the no man's land.
Nope, it's in the
No,
vein.
it's in no man's land.
See that? We fell right into the vein. It's unbelievable. Huh. Okay. Just going to hold a little pressure. So I'm going to ask Sandeep to use the ultrasound
Yeah,
because it's so diseased. Normally, I'm going to leave the wires in so he can see the two. And then in the meantime, what I'm going to do while he gets ultrasound access, I'm going to have Ray go to the arch. And I'm going to go ahead and go up with the pigtail to get our intervention started. So while Sandeep is demonstrating access down there, let him interrogate the vein, and when he's ready, he'll call us. What I'm going to do is I'm going to go to the arch. So I know a lot of people do radials. Obviously, being peripheral specialists, we do it a little bit differently. One of the things we do is we use the woolly wire versus any other wire and just advance very, very slowly. Everybody seems to be in love with the glides. But as you and I know, can you pull it out even further for him? But as you and I know, Lomac? Not yet. Yeah, let him interrogate, and then when it's time to go to him, we'll go to him. So as you and I know, the glide wire is very, very dangerous up top, right? The just low mag and come all the way up top. So I'm just feeling the wire right now. The movement of the wire is very smooth. He's not having any problems. Show me up top, please. See, the wire is already up there. With the woolly, you really don't have to worry much about any nonsense. And the woolly kind of found its way. That looks like the heart there. So now I'm going to ask Ray to give me the pigtail, and then we'll see how it happens. The pigtail is loaded, Ray?
So you took a radial access as your primary goal of intervention, your diagnostic, because you already have a catheter in the right groin.
Well, the right groin is not going to work, and I think this is the mistake that people make. I think when you have this kind of difficult blockage that this poor gentleman is suffering from, you know, the problem becomes is that, you know, the right groin really is not going to be the way to go here. You know, the right groin is not necessarily going to allow you to cross this lesion and work. And I think this is the problem here. A lot of people just try to use the right groin, and I think that's going to be an issue for this gentleman just because of the fact of how his anatomy is. His anatomy is not going to allow you to do the right groin. And a lot of times when you have trouble crossing up and over, it's worthwhile to just do a quick Aorta Graham.
I think that's a great point, getting radial access for your diagnostic aortogram for better visualization. Like PK said, right common is also disease at the ostium, and then you have a CT of the left common iliac artery. So
hang on, my friend.
Great to have another access point just to make sure you can visualize especially when you're trying to do a bifurcation stenting and trying to create or preserve the carina. I think it's good to have a catheter from up top for good visualization and parking of the stent at the right spot. So great thought, PK.
So what I'm going to do is I'm going to push this wire down into the aorta, right? This catheter, if it goes. There it goes. So what we're going to do is just do an arch aortogram here in the LAO view, or in the AP view is what I'm going to do. Ready? Ready?
It's amazing. When we do radial, we want it into the ascending, it doesn't go. When we do peripherals, we want it in the descending, it doesn't go.
Well, yeah, I mean, a lot of times these patients have unwinding of the aorta and all that, right? So there it is. So you see he's got a regular arch, so it should go without an issue. And it's always a good habit to get started with the arch aortogram. So we're going to go ahead and go with the wire. Put me back on corner, please. A lot of times you need a steerable catheter, but mag up, Ray. So in these kind of cases, we're just going to go ahead and So a lot of times this doesn't quite want to go. So we'll see. Let me show me above now. So what you want to do is here see how this responds, how this wire goes. So this wire seems to be going. So this is where you need to pull the catheter back a little bit, right? This is what we call as the Fosbury Flop. I don't know, for those of you who know Bob Fosbury. I'd like to know up top, right? You always have to watch up top. So I'd like to know who knows Bob Fosbury. See how that does that? So this is the Fosbury Flop. So Bob Fosbury invented the flop that all high jumpers use. And this is how he did it. He basically arched his back over and then dropped it down. So you can see that's the Fosbury Flop. When you go down the descending aorta, do not go with a wire, because you might be able to get into all different things. So now we're in the distal aorta like we want to be. Now we have the ability to do whatever we want to do. So now we're going to go back to Sandeep to see how he's doing with access. Sandeep, do you see anything? Can you show the camera on the access, please? It's a very, very diseased vessel. Can you show the camera to the ultrasound machine, guys? So Sandeep, if you can describe what you're seeing. Sorry, sir, a little pressure.
What I have here is on the screen. Are we on the screen? Oh.
No, not yet. I don't think.
No, he has to see it, my friend. You have to go there. He has to see it. Go ahead. All right, if you can't see it, then we'll set it up for the next time. But we'll go ahead. Let's see what you're seeing.
So
Yeah,
focus
that's
on the screen. So, if you look on the screen on the left-hand side, when I compress, is the vein. So by anatomy, the structure lateral to it, or on the right hand of the screen, would be the artery. I'm going to try to go for that.
Do you want to put some color on it or anything?
It's pretty.
No? You're pretty clear.
Yeah.
It's very clear. You can see it's non-compressible. It's definitely the artery, huh?
Don't move, sir.
Yeah, you can see it up there very clearly. Very nice pictures from
Yeah,
our
sometimes
our
it's really
team.
hard to see the pulsability because
Well,
like
it's
I said,
a very
low
underfilled
flow.
artery.
Right. So
I mean, I usually get this in the sleep, and I probably could just keep trying, but I think there's a good option to show how to do this. So. No?
you're right there. Now it's going to pull back and see if it comes out. So pull back a little bit more.
I had a little flash.
Yeah,
Yeah, sometimes it rolls over too. So
you gotta have gentle movements. That's the key. Worst comes to worst, I'll get it in through the anatomic route here. That there's no flow at all. All right, let's see fluoroscopically wise. Now, is it essential to get this access? I don't think we're in personally, but we'll see. Yeah, we're not in for sure. We're very low, but let's see.
looks like a profunda stuff also.
Might be, but at this stage, I'll take anything. Nope.
No.
Nope, we're definitely not in.
No.
Okay. Let him go back. He needs to be higher. You got to be at the common femoral. You're definitely lower.
Bring it down.
Actually, even if you get into the SFA, I'm okay. So Vishal, let's talk a little bit about strategy for this case. Other than access, which is the major issue, as you can see, what else can we do for this patient?
Well, I mean, except for the access, endovascular approach, I guess, is the first and the best approach in this case. Patient keeping in mind his risk factors and his presentation. Worst case, if he failed the first or the second time, then I would probably obviously get a surgical opinion to see if we can do aortic fem bypass. But that's again, it's an open surgical repair. So if the patient needs it, we definitely go for that. But we always give an endovascular first approach, especially.
Yeah, I think part of it is also understanding that you can definitely get an endovascular approach to do this. If you can't, then just go with a surgical approach.
Right.
I told him now to just stick the SFA, because I'd much rather have SFA access.
Yeah, I think, and obviously doing an endovascular approach, you have to figure out the anatomy.
New needle, guys?
The ostium, the CTO, the proximal cap, the distal cap visualization is very important.
So I'm going to give him 2 more tries, then I'm going to go back to my technique, which I know will work eventually. All
Sandeep has to do is just go a little higher up, and I think you should find the bifurcation above it.
So can you see the wires or no?
If he's compressing the vessel now.
He's compressing the wires?
Yeah.
So he's now going for the artery.
Don't move, sir, don't move.
Try your best not to move, my friend. It's very difficult, I know. Only way we can try to save your foot here.
Right there. That's all. think you want to decrease the gain. It's a lot of gain, but I'm essentially getting an ultrasound access like Sandeep. There it is. You popped in right there. You could see the needle go in,
Yep,
bunch
and
of
now
the
we're in.
superior wall.
So now we definitely have arterial flow. So now we're going to go ahead and rate. 1 second. Show me down. Okay. That's fine. Let's take a picture. Let's take a picture. So remember that you don't want to take any chances here. DSA. I don't know. No, we'll see. So I'm going to pull out these other 2 wires first, because we definitely don't need those 2 now. Put me on coronary, Ray.
I think it looks definitely internal. It's probably in that
Now we're
lateral
in.
circumflex artery. So now
Now
you're
we're
probably
in.
in the.
See? So that was good. So you can see the training here at Sinai is pretty good. That Sandeep was able to get access live, which is a good sign. So
Test in the morning.
yeah, a little stress test, make you do it, right? Show off in front of Vishal, who's our guru here at that.
Thank you, Sandeep, for keeping the
Vishal,
flag up.
Vishal is our guru in that. Everybody knows how good Vishal is at ultrasound access. He did multiple in Link, New York, Link Mount Sinai. Can I have a DSA picture,
Let's
please?
start with 5.
So now that we're in, what you always want to do,
725
guys, is take a picture to see what it is, right? And I'm going to have Ray just mag up a little bit. A little higher. So now what you may be really surprised at is how open this vessel is. Can you get that out of there? And see, so we got a nice, reasonably healthy segment. So now it's very important for your equipment choice. So we're going to go with a supercore wire. Right, supercore wire is going to go in. It's going to give us a lot of support. Okay, so I'm going to curl my supercore wire up here, which is fine, right? And then I'm going to walk this out. Now I'm going to get a dilator. Sorry, sir, a little pressure. I apologize. Just my finger there. What's the matter? Where's the pain? Right here? Oh, I'm so sorry. I'm so sorry. What happened? Okay. Hang in there. There will be no more pain in a second. Okay. Okay. Little pain, sir. Okay, hold on. I'm so sorry. All right, give me a 7 French 25 centimeter sheet. So the other thing now, once you dilate the tract with a 5 French, now you want to go with a 7 French 25 centimeter sheath, and you want to make sure that you have a what is it called, a marker at the tip of the sheath.
The bright tip sheath.
A bright tip. So this is going to help you to be able to cross. Now Liz hasn't given any heparin yet, right?
A little bit in the
A little bit in the arm. So now, as soon as we get access in, Liz is gonna. We're gonna just give about 5,000 of heparin.
Let me draw ACT.
So let's give 2,500, 3,000 of heparin, Liz. So now you got to be very careful not to pull the wire. Already the wire's pulled, so I don't like it. So show me above, please. So I want everybody to see what I'm doing. Show me below, please. So you see the soft part of the wire is what you got to watch out for. That's your enemy. See, that's wrong right there. So sometimes you can't give too much tension to allow the soft part of the wire to go in. See? So what you want to do right here is try to jimmy this in, and it doesn't seem to want to go here. So I'm going to walk it out again and give me the 7 dilator, please. So I'm going to just go with a 7 dilator. Dilate the tract again.
7 short, Damien.
7 dilator, Damien. So you really got to dilate that tract properly to get the sheath in. And then once you get the sheath in, you can go.
Yeah, that's a great point. I mean, the supracore gives you that soft end, so there's less of trauma, but at the same time, like you said, you have to watch that the soft end doesn't become your enemy instead of your friend.
Yeah, you got to make sure that the soft end is staying above, you know, and based on that, you can decide. So obviously there it goes. So I'm just slowly, see there's a lot of
fibrotic
scar tissue.
Right.
So I'm just pushing it back and forth. Now I'm going to go with the dilator again, the 7 sheath again. Because it's very important that you don't create, a problem and lose your wire. I know in Link Mount Sinai, Dr. Guja lost the wire, and we had a lot of trouble getting it back, but we were able to get it back. And it was a similar kind of case. And, I blame myself because we didn't communicate, me and Karthik. And I think that's what happened when you don't communicate. Sorry, my friend, that's it. That's the worst part. That's it, no more now. So now you see, guys, my sheath went in nicely. Now I'm telescoping my sheath in, and now I'm in the vessel, and I'm safe because I've got a 25 centimeter sheath. Now, one of the things that Ray has done, being Ray, is he's given us two manifolds, which is going to help us show the pressure both bilaterally. Come flush forward, please. So, nope, just flush forward. Just flush it. Just inject forward, get the air out. Okay, get the air out. Good. Now he's going to pull back and prep it up. Now the patient shouldn't have any more pain in the groin. He's still going to have pain in the leg, obviously, but not much in the groin. Thank God for that. So now you can see the waveform is very, very blunted, which we would expect in this, almost like a no waveform. Right. And you can see the gradient. Show the gradient, guys, on the monitor. All right, my friend, now we're going to get to work. Hang in there.
Heparin.
So now we're going to give a little bit of heparin.
We gave 3,000.
Okay, we gave 3,000 of heparin. Now I'm going to just take a picture. Okay, DSA, guys. And we want to see what is going on here to really understand what's going on. So a picture from below, right, showing us the nub in there, right? Mm-hmm. So we got plenty of room. And I'm going to do an RAO view as well for us to see. I'm sorry, my friend, hang in there. And I'm going to inject from above and below. Ray, ready? So Ray's going to inject from above. I'm going to inject from below.
Don't move, sir. Don't move.
Go ahead. So you see now the connect the dots. It's there, but it's not that far. Does he have to go to the bathroom, Ray? Liz? Is he okay? Okay. So now we're just going to work. Try not to move, sir, a little bit. I know it's hard. So what I'm going to do is just take this catheter and just lower, Ray. This is just any angle tip catheter. Little dye, please. Show me above.
From below?
You should put me on coronary. Give me a little dye. So we're just going to go up. Pee-pee. Yep, sorry, so you can go. Don't move. Okay, we're going to stop right there while Liz does the pee-pee team. So we have a pee-pee team in Sinai. So we have a pee-pee team in Sinai. So the pee-pee team head is Liz. So she will take care of our patient.
Everything's good.
Everything is going great.
Right? Yeah, you.
Confianza.
Awesome. Yeah, I know. It's great. We always have to define the anatomy, the proximal and the distal cap, because it's very essential, especially in the iliacs, so that you give due concern because of the anatomy of the iliac vessel and where it's positioned, and a high chances of ending in trouble if you don't do the right thing. So taking orthogonal views and doing stuff is very important, specifically for people who want to do CTOs, which is a very high complex DAS-D lesion. So
yeah, so normally we don't get radial access, Vishal, but here we know that we're going to have to treat the right side anyway, because of the high-grade lesion. So we got 3 access points. So now we're just going to go. Now, what's your wire and how do you wire these things usually?
Well, in iliacs, always respect the iliacs, and I'm very conservative to start with. So I usually start with my stiff 014 wires, try to poke around, see if I can find that micro channel in there, and see if I can connect the distal to the proximal cap. But if not, then of course slowly escalate to an 018 and if needed an 035. But I'm very careful, just try to poke around and get a feel of how it responds.
I totally agree. We generally start with an 014 because, again, I think I'm one of the few who many years ago started talking about the fenestrations on how these close. And I think having an angle catheter with the ability to poke around and try to find the fenestration really helps. So now we don't want any dye from below. You always want to go dye from above now to try to torque into the vessel. So a little dye from above. So you can see Ray is giving you a little dive from above. I don't know if that's in. No, it doesn't look like it's in. So we're going to keep trying here till we get to the point where we're going to be able to get in. So a lot of times, you know, the issue here is where are we, how's it going, and whether we're going to get there. And sometimes you may have to come from both above and below. So here, it looks like it's freely floating, but the question is, where is it freely floating to? And I think this is sort of the advantage of trying to come from a retrograde access versus an antegrade access. See that?
Yeah, that's
good. That's how you kind of do it. You know, you just kind of do it in a manner where you try to find the plane based on where you are. So then when you find it, then you just slowly advance by moving the wire, and the Ray's going to give us a little die. And then at this stage, remember, you got a really tight 014 wire, right? So if it loops, which is good for you, and then you're just going to loop it up. So at this stage, once you're through, you're going to try to just jimmy. I remember Liz told me she had a cousin, Jimmy. We're gonna push this. We're going to jimmy this up. So once you jimmy it up, now you're up in the aorta with this. And then now we're going to see the blood flow, and you can see you have great blood flow on this end. But remember, all this would not have been possible with Vishal without Sandeep. As you see, Sandeep is the one who got us the access, and Sandeep is the one, thanks to your good training, showed us how to get in with ultrasound. So I really want to thank Sandeep. How about you, Vishal?
No, I definitely thank Sandeep. I wish he would have listened earlier.
Vishal.
I couldn't argue with my boss, so I kept quiet and waited for the ultrasound. But I would have gone ultrasound. Even Sandeep knows he would have gone with the ultrasound or head go. Right, Sandeep?
No. We were really hoping we'll get with the that roadmap.
No, actually, this is funny because, you know, we talked about how difficult this is going to be because of the calcium. Okay, walk it out, guys. Walk out the catheter.
Yeah.
So we were talking about this, and clearly, you know, it proved us right. So now everybody, what you're going to see is just enough laughing and talking, as we always do here. You've got a 7 French sheath on the right. You've crossed the lesion. Now you're going to go with a 7 French sheath on the left. Now, if we weren't going to stent the right iliac, then at this stage you probably wouldn't need right access, okay? Because the reason you get radial access is to come from above if you fail from below. But here, since we know we have an osteal lesion on the right, we're going to have to do kissing stents. We're okay with getting 3 access points, and now you're going to see how much the access above is going to help you land the stents. So right now, we're going to go ahead and get another supercore wire.
So what's your stent strategy, BK?
Well, you know, this had some layered thrombus in the aorta. The poor gentleman has been suffering like crazy. So what we're probably going to end up doing here is try to hit the ostium directly, and that's where the Aorta Graham is going to show us. Can I have another supercore, Damien? And then, so once we get so the ostium, we're going to land the ostium directly, because I think we're going to have to go up and over after we stent to fix this common femoral, or send him to our surgical partners to do an endarterectomy, and I think we'll decide that based on how the common femoral looks. It may all be underfilled, and which is what we're hoping for, but we'll see how that looks, and I think you have to understand that. So now we're taking another supercore wire, which is a very stiff wire, and we're going to put it into... Yep, there's a little bit of difficulty on top. I'm already being warned. So, you know, obviously Dr. Singla helped us get access earlier. So what I usually do is just push this all the way up into the aorta, way into the distal aorta. So this way I don't have to worry about anything, and then push my wire up. Obviously not take it to the carotid, which the other one is not the carotid, obviously. It's my that's my pigtail. That's my pigtail. So now I'm just going to walk this out.
725.
So they're going to get another 725. Okay. A little pressure, my friend, on the right side now. Sorry, breathe, don't bear down, please. So now we're going to wait for our 725. They're actually manufacturing it now somewhere here. So no. Yeah, he's going to, Dr. Singla has a comment or a question.
So what about predilatation?
So it's a good question, Vishal. Predilatation for the,
especially we know
for the CTO.
Well, I mean, in this case, because you know you are so intraluminal, there is nothing against predilatation. But if you think you went subintimal or you were far away from the vessel and re-entered, then I'll be very cautious in the iliac, because the chance of that calcification causing a perf is very high, and then we can end up in big trouble. So in this case, I think it looked pretty much straightforward in the sense you were lumen to lumen connected. So giving it a 5-0 or a 6-0 predil to create a track, I would probably do that before I go and deploy.
Yeah, I agree with you. In my practice, I generally go with a 6-0 predil. We have CT measurements of this, so the CAT scan was done, and I think Generally I don't do CAT scans to measure this stuff. I don't think it's that necessary. We generally go with this. But in this patient, because of his very difficult anatomy and what he has failed in the past because they couldn't come from above and they couldn't, find a lumen, we said to ourselves, let's get a CAT scan to really be clear. And the patient is a very, very good patient. He really understands what's going on and the difficulty. Sorry, sir. Breathe, sir. Breathe. I apologize. Okay, nope. I need a nick. I need a nick, guys. And he really understands the difficulties that we're having and why it's important to be slow and methodical. 1 second, I'll do it. So, at this stage, what we're going to do is we're just going to make a little nick of the groin. So the other question is, Vishal, a lot of people are moving away from 7 French. What is the French size that you use normally in these kind of cases?
I always use 7 French. I don't go below 7 French at all because one is for visualization, to see if you want to inject through the same sheath, you can inject through a 7 French. The other thing is using covered stents.
Sorry, sir, breathe. That's it, no more.
You have to be very cognizant of the fact that you might have to use a covered stent, especially in this case. I would probably might go covered stents as first strategy.
Real.
Keeping in mind the calcification in the CTO, but always a 7 French gives you that option of putting a covered stent if you have to in case of emergency. So now one French up, I save my day, I'll be happy.
All right, now we're going to check another ACT. So we got another ACT going. So remember, that part of that is now we're monitoring hemodynamically. His heart rate hasn't changed. Blood pressure is very, very good. Now the ACT is important because you've got all this crud in the distal aorta that he's going to move, that you're going to send. I mean, he's in so much pain. So what we're going to do now is we're not going to balloon the contralateral iliac, meaning the right side. We're going to balloon just the left side. So now I have 7 French access. I have a stiff wire in. God forbid there's a perforation when I balloon this. I have a balloon in the left side. I've got access from above, and I've got access from the right side. It takes me a second to put in an aortic occlusion balloon from my right groin. I'll do it sheathless. We have our trauma kit ready, or not our trauma kit, our rescue kit ready, and then we'll go ahead and do it. So now we're going to load the 6.0 balloon into the contralateral side. Can I have a 6.0 60, please?
So PK, what's your heparin strategy? Do you wait on to cross the CTO, especially in iliac CTO, and then give heparin and keep the flush on, or you give it before, head on?
I got to tell you, in this patient, we've got radial access, we've got 261. So we're above 250. So I think we've got a contralateral access. We've got a pigtail in the aorta. So what we tend to do is we tend to give heparin up front. If we're just doing from an iliac perspective of a short CTO, if it's calcified, then we may just give 1,000 or 1,500 of heparin, kind of just to make ourselves feel better, and then we go ahead and do it. I think the iliac has such great flow that you really don't have to worry too much about heparin in a non-occluded iliac. But in this kind of case where you have layered thrombus in the aorta, we have the old films documenting what the flow is in the SFA, so we know what the SFA is. So here I was a little bit more aggressive, gave 3,000 before I crossed, and now I gave another 2 to get him up to 5,000 with an ACT of 260. So now I'm going to go ahead. I'm going to jimmy the balloon across right there, right? So now that's pretty much where we need to be at the initial stage. So I'm going to tell the patient what we're going to do. Sir, we're going to go up with a balloon. You may feel something funny. Shouldn't have much pain, but let us know if you feel anything. And it's important because we have a very good patient here who will let us know what he feels. And we're going to just take a quick picture, just a non-DSA shot here from above. And I think that's the advantage of having the catheter above. And you can see right now where we are, right? So I can even go forward a little bit more, right, into that nub right there. So this is the aspect. You have a very calcified aorta, right? Let's go right there. Let's go up. So again, you look at the basics, right? Hypotension, bradycardia, and then obviously pain. Pain is first. So you can see the balloon expanding with a 6 millimeter balloon. So we're just going to go up to 6, whatever nominal is. Okay, 7, 8. There you go. See, so that's that's a differential expansion. So you worry about that, But it is what it is. I mean, you're either going to poop or get off the pot, right? So where's her? In the leg? In the foot? Yeah. Oh no. Right here? Yes. Right here? Yeah, that's where he's having pain. Okay. So leave it there. Okay, DSA array for me. So, what we want to do here is we want to keep the balloon in place, leave it up for a little bit, and then just watch his heart rate, which is rock solid. and his blood pressure also is rock solid at this stage. So, okay, ready? DSA, you got me on DSA? Okay, down. So now we're going to go down with the balloon, and immediately the first thing you want to do is watch your hemodynamics. What's happening with the hemodynamics as the balloon comes down? It's normal to drop a little bit, and you see the pressure is going up in my common femoral.
Beautiful.
So that's a good sign. And it's normal for it to drop a little bit because now you have release of that thing, but you don't want it to trend way down, and it's not. It's very rock. So Liz, Tom, just 1 second. I'm going to take a picture. Sir, 1 second, sir. I'm just going to take a quick picture. So now we're just going to take a quick picture to see with the balloon in place. Now, guys, this is very, very important. I want you to understand this picture. The importance of this picture is going to tell you if there's a perf, you have the balloon right there. You have a 6-0 balloon, you have a chunk of calcium, but you can include this perf because up in the aorta, you've got the balloon occluding the ostium of the common iliac. So now you can just go ahead and get this done. So what we're going to do is we're going to avoid the ostium. I don't think we need to touch the ostium. And we're going to, now the question is because of the size of the iliac, whether we put a covered stent. So this is a 60, so I'm going to need an 8059 covered stent, if we have it.
On the top?
Yep.
No, 8059, no.
No.
It does.
No, 8059 VBX, we used it the other day. We used one the other day. Wait, hold on. The other one, no, we used a 39.
No, we used a 7059.
No, we used an 80. The other day we used an 80. 8 French, do we have a 7059? No, right?
We have any 7059s in the back?
750?
No. That's
No, that's a Vibon. I need a VBX. So, Chris, can you see? I need a VBX, a 8059. You know what? Open that.
7059.
Open the 8059 for me, and let's see if it goes through the sheet.
Yeah, I think it's a great spot. Here you can easily see the internal iliac coming out right distal to the lesion.
Last week we went through an 8
we
French
should
sheet?
be able to park our stent perfectly well if we get that
7 French, yeah.
8059
We did 8059.
VBX.
Yeah, so it's interesting. So this is, I'd like to talk to
I'm gonna
Gore
look
and
at
find
that.
out what happened here. So we did a case similar to this last week, live actually, and we used, yeah, right, yeah,
Monday.
Okay.
Monday.
So what happened was, now look at our pressure. It's even better. Look at that. So the argument here is if the VBX doesn't go, can we use a balloon expandable? And I want to talk a little bit about when you use balloon expandable and self-expanding stents, Vishal. In CTOs.
I mean, essentially it's all about the placement. I mean, balloon expandables most of the times by the book we use when we have to exactly park at the stent, especially in these cases, you have to do an ostial covering or you do the carina, then you would prefer a balloon expandable stent. But if you're away from the ostium and have a little bit of more flexibility, then using a self-expanding gives you a good option. And the other thing is the sheath size. Self-expanding can go to a smaller sheath and you can balloon it up to a bigger size. Balloon expandable need a higher grade. So
no 7059?
in this case, I would probably prefer a self-expanding stent because that gives you more leverage and, of course...
well, that's very interesting because in the common iliac, you're not going to worry so much about self-expanding versus balloon. I don't know, Sandeep, you reviewed that in a journal club for us.
Yeah, so
Can you talk a little bit about Dr. Zeller's trial or the trial on self-expanding versus balloon?
So, the conventional wisdom is for common iliacs, you want to go with the balloon expandable so that you can really nail the ostium. And for external iliac, because there's a lot of movement, lot of tortuosity, the conventional wisdom is to go with the self-expanding. But there was a recent study, they put it in Jack, Dr. Zeller's group. I don't know the exact numbers, I think it was 150 plus, where essentially they showed that regardless of common or external, the self-expanding had a 12-month patency was better as compared to balloon expandable. But the only, like when you go into the nitty-gritties of it, they do not give a subset of where they really had to write at the ostium, like they should have given a breakup that where they had to position the ostial stents. They kind of just give a common iliac. Common iliac, like in this case, if we didn't have a disease on the right, I would really want to avoid the ostium because I want to keep my options of going up and over, and there is a landing zone of about 5 millimeters. This case, I would not use a self-expanding for that reason.
So give me 839. So I think Sandeep is right. We probably used a 39 last week in a 7 French. 839 is a 7 French, and 859 goes to an 8 French. Now, remember, we could easily upgrade this to an 8 French, but to me, At this stage with the groin and all the issues, I'm going to go with a 839 with a 7 French, put 2 of them in, and then overlap them. Now, the issue is, that's why the question is also, before I get technical, let's talk a little bit about what Sandeep said. So, Vishal, can you comment a little bit on the old data, and I know it's really ancient now, the COBAS trial, on what your thoughts are with that?
No, I mean, I guess before I go to the COBAS, I guess just to expand on what Sandeep said, the trial which he's talking about is the ICE trial, which was published in 2017 in JACC, and it had like 660 patients, and 25% had calcification, and he's right. The data eventually suggested, they concluded that the restenosis rate in the self-expanding stents were less at 12 months as compared to a balloon expandable stents. And so that was the main finding of the trial which they published. And again, COBAS trial, like you're talking about, essentially was using covered stent in calcified lesions, and but that was compared against just plain old PTA. So that we have to understand nowadays that we don't really do plain old balloon angioplasty in the iliacs anymore. Primary stenting is the primary treatment of choice in iliac lesions. So the COBAS trial was essentially comparison of covered stents versus the balloon angioplasty, and which showed that covered stents did much better, both
Give me
in
another
patency
8039
rate
if you have
and the target lesion revascularization in the COBAS as compared to the other arm. So great points, great thoughts, and like you said, always to consider the sheet size in these cases and the stentings you require.
No, what is that?
That looks like a short.
It's a 7 French? All right, well, leave it. We already opened the 8 now. So we're gonna take a picture. Well, let's just see. Let's just see.
So what size stent does this become?
It's an 8039, and what I'm gonna do is now I want to avoid the ostium, so I'm just gonna go up to the level of where I think it is a little die. I want to go a little bit higher, like right there. Ready, guys? DSA. See, now you could argue that you should put another one on the opposite side. You know what I'm saying? So give me a 7059 on the other side, guys. So here what I'm going to do is I'm going to do bilateral kissing stents to start, because, you know, this way I know I have a lot of moderate disease by CT on the other side. So I'm going to cover both with.
You want to switch this onto this? And
so PK, just for the viewers,
walk it out. So one of the things we may do now is switch the 8039 to the right side, and then go with the 7 on the left side. Now remember, can you talk a little bit about the VBX, Vishal, and how you can expand the VBX and why?
I was going to ask the same question. Essentially, is like usually we expect the iliacs are usually 10, 12, or even 14 millimeter in size, depending on how big the person is. And here we're using a 7 and an 8.0. So just for a learning process for Gore VBX, we can actually go up on a 7 and an 8 French, and we can post-dilate it all the way to 11 and even 13, depending on what size stent we are using. So they have a chart in the back which gives you an exact configuration of how a 7 or an 8.0 stent can go up to 11, 12, or 13, depending on the balloon we use for post-dill. But you always have to consider, once we expand the stent has to shorten, because you know, how is the extra material going to come? So we always consider that margin of error where the on expansion from an 8.0 to a 13, there's some degree of shortening as well. So we always make sure that our lesion primary is covered and we don't shorten enough that we miss the lesion itself. So very important to consider.
And also, you know, it's important to understand that you know, the shortening is very little in this particular stent.
Correct.
So, you know, but it does shorten. So when you're doing a CTO and you're worried about the proximal edge dissecting or anything, you got to be a little careful. So
yeah, something to keep in mind. I mean, we always cover, but there is minimal, but always there to keep in mind. You don't want to miss what we're aiming for.
Now I'm up top. Now I'm going to decide my positioning of both stents. So first I'm going to get 2 end deflators, get everything ready. And all I care about here, guys, is the ostium. So everybody worries about X, Y, Z. Just stick with the ostium. And Liz is going to watch everything for me. Being, you know, the iliacs are obviously very, very, important vessels for us. And also for the fact that this is a very dangerous intervention if you don't do it right. So now we're just going to take a quick picture with Ray. So now you can see I'm actually okay with that, Vishal.
Yeah, looks good.
So because you can see here that there's a tilt to the aorta, right?
Right.
So you've got the proximal edge of you can see the right common is right at the ostium. The left common is right at the ostium. I kind of like this.
I think it looks
What
good.
do you guys think? I like this.
Maybe a dot on the right end because the way it is sitting.
Okay.
The outer edge,
Makes sense to
the
me. I'm
outer
just
edge
going to
will
go in.
jump
We can
down.
take an orthogonal just to but I think I
I'm
like
going to
it.
go right there.
Yeah. Just-
Let's take another picture,
I
right?
don't know.
I'm not happy with this. We can go in with the left as well then. Let's see. No, I'm definitely not
That's-
happy with this.
Okay.
Yeah,
So I'm
it's
going to
we
come
need
back a little
too
bit.
high up.
Yeah.
I think the earlier position was better.
Right
there.
Little die right? Yeah, I like
Yeah.
this.
Yeah.
Go up, guys, together.
Okay. Negative. Ready? Negative. Okay. Going up. 1, 2, 3, 4, 5,
Liz.
6, 7. Drop to 7. Again.
Beautiful.
Okay. 8, 9.
Very nice.
Not 10. Okay, I'm 10 now.
11, 12.
11, 12, and down.
No. Show me
Okay.
the distal.
Okay.
Okay, now give me come off DSA. Come off coronary. Okay, down. So now this is where you really got to watch your pressure, okay? So now you've come down, the stent's coming down, waiting for the pressure to come back up, and you'll know very soon, okay, which again is normal for the pressure to drop on one side. Okay, now we're going to just go ahead and just
Beautiful.
do a DSA picture. Again, it's overkill, but I always want to teach safety. We're going to do a DSA picture with the balloons in place. If we need to go all the way up to the aorta, we will, and occlude it, we will. But in this case, I don't think we'll need to.
I can see it covers perfectly fine.
So you see,
Great.
it looks pretty.
Perfect.
It looks pretty. It looks, the covered stent, both lesions, and you've saved your bifurcation to go up and over and treat the contralateral if you want. Now we're going to leave this in place for now. It doesn't really matter, but leave the right in place, and we're just going to work on the left now.
Yeah,
So
there's
now let me see where my sheath is. Look where my sheath is. I'm going to leave my sheath right there, and I'm going to have him walk it out very, very slowly. Again, you also have to watch where your wire is distally, right? Remember, you can watch the heart. You can see whether there's any PVCs. That's where Liz is there watching, and Ray's there watching. It's going to be tight. We know that. That's why I'm holding the sheath.
Okay.
And once we're out, we'll see. Good. So now we're out. Now we're going to see the pressures almost equal. If the team can show us the hemodynamics, which they are, the pressure is almost equal. So now what I'm going to do is I'm going to go contralateral here.
Yeah, I think there was some external iliac lesion as well, but I don't know.
Well,
how
we're going to do two pictures. We're going to inject from above and below. So I'm going to inject from below. Ray's going to inject from above.
Fill it up.
Always prep your catheters, prevent clots, because a lot of this
Saline in it, yeah. Okay.
goes, So now we're going to inject from above and below.
Yeah, right there.
Ventilation, absolute.
Don't move, sir. Which is fine. A lot of reperfusion at times. They get pain. I'm going to do it from below now. Yeah, so he's got a lot of disease. The question is whether we just use the self-expanding here since it's not occlusive, and
Yeah.
then we decide. Because problem is you've got that double shadow up top, which I really don't like. You see that double shadow that you see Vishal right there?
Yeah, right
But
behind
the question
stent.
is that a collateral or not? And I think, the subtle things that you got to pick up as an interventionalist, you got to pick up subtle things before they become a problem. So what I want to do is I want to evaluate that double shadow first before I choose my stent. So I'm going to go, sir, don't move, sir. I know it bothers you. Put your leg straight. Thank you, sir. Thank you very much. So what I'm going to do is I'm going to low mag. And I really want to see how this feels now. This is going to help me a lot. Ready? And it's going to be from above, guys. That's the key here, and girls. Inject.
Yeah,
So
I think it's just that stent being just a little bit, expanding a little bit more to oppose on the wall because it's like an 8 we used.
Vishal, I
that's
couldn't
what it
agree
is.
with you more, but I think it's important to
No,
understand.
always very important.
Yeah,
You're
it's
right.
important to see if there's any retrograde dissection, because if
Exactly.
there's retrograde dissection, it may tack up or it may become a pseudoaneurysm. So what you need to do here is, now that I'm convinced there's no retrograde dissection, I have an internal iliac that's patent, I want to preserve this internal iliac. That's what I'm thinking. So, and I know this is not the occluded segment, right? So my only concern is if I put a covered stent across that, I'm losing my internal. Contralateral internal is where my eyes immediately go to. It's a very diseased contralateral internal. So at this stage, I'm going to go with a self-expanding stent. So I'm going to choose an Abbott 10060 or so, I guess.
Yes.
and then or 80, and then what I'm going to do is I'm just going to go ahead and do that, and then I'm just going to go ahead and leave my common femoral if I don't have a dissection, and send that to our surgeons to do an endarterectomy. And if they don't do an endarterectomy for whatever reason, comorbidities, we told you about CAD, COPD, all that other stuff, then we'll go ahead and just do a endovascular approach. Vishal, I know you were part of that wonderful case we did with Dr. Zeller and Dr. Marin on the debate of the common femoral.
Right.
Can you comment a little bit about common femoral to everybody?
Well, I mean, common femoral is always a tricky area. The surgeons,
You have 80 or no 80?
the
Okay,
surgeons
80
love
is
to
fine.
do the endarterectomy.
No,
Nowadays, the data, especially suggesting on atherectomy and PTA from Zeller's, has shown that the, especially the trial has shown that it works as equivalent to surgery. But again, from a surgical aspect, it's just a 1-inch incision like the surgeons claim under local anesthesia or epidural it might be, with great patency results of more than 95%. That's where the surgical data comes from. But nowadays, with the involvement in the endovascular technique as shown by Dr. Zeller, that there is that endovascular approach is becoming a viable and almost an equivalent approach. So it's always good to consider in patients who are not candidates for endarterectomy, keeping in mind the morbidity, the nerve damage, the seromas, and the other associated issues with surgery, that endovascular repair is feasible, possible, and is doable. So.
You know, and I thought that was very well surmised, Vishal, because I think the debate was very, very clear. In that even Dr. Marin admitted that, you know, it's important that we keep our mind open. I mean, Dr. Marin rightfully talked about, I don't want to, quote him, but just to paraphrase, he rightfully talked that, you know, the data and the ease of surgery and all those things are there in common femoral. Clearly, Cambria's data showed the patencies was phenomenal, but the comorbidities was also high. So, you know, the TICO trial, I know it's an intermediate term result, but clearly giving some positive, results with the common femoral. And I think also, you know, as we go forward with the use of drug-coated balloons and newer generation stents like the Supera, I think clearly there may be more of a role for endo. But again, I think if it's surgical options are there, then I think you should also think about surgical options. So you can see here, we're going with 100 stent. The hope is to cover the whole thing. So let's see whether I can cover the whole thing.
Oh, yeah.
That's a little too big, huh?
Yeah,
But
80 would have been a right side.
But you know, I mean, you know, maybe we go with an 80. Let me see here. I mean, we don't have a 10080. We have a 9080.
Yeah.
All right, let me just see here, just to understand how far I have to come. Now, this is where I want you guys to understand. So now he's going to go ahead and prep up my sheet here, and you might be surprised that this may be the right size. But let's see, little die here, Chief. Okay, so I need to come about up to here, right? I think that's reasonable. Let's take a picture of DSA, Ray. All right. I think that's the right size. I mean, right there, the lengthwise, it's nice. So now let's decide whether up top we're too high. I don't think we're too high. You see that, Vishal?
About 1.5 centimeters.
Yeah.
Right? I think it's worthwhile. I can even, this way gives me a little, I'm going to pull back slightly to allow me to land it briefly in the you're going to have to cover that distal external iliac anyway. So I'm just going to, little die. I'm going to want to land it in the right spot. I think right there is pretty good. I'm just going to come back a little bit right there. Walk this back and take a picture here. I like that. Vishal, what do you think?
No, it looks good. I mean,
Honestly, what would you do here?
well, we're technically entering the territory of CFL, like you can see here. We're below the inferior epigastric. So
Right, but I mean, you're about 1 cell or 2 cells below it, which I think
Yeah.
is reasonable. So I can even go up slightly right there, little
that's
guy.
good.
Right? Yeah, I'm gonna
Yeah,
deploy here.
that still looks
Let's
better.
go
than-
up, guys. I don't care about the proximal. I'm watching the distal edge. Ray, keep giving die when I tell you to.
Yeah, because you have decent overlap proximally, so you don't have
Yeah, I mean,
to.
a little overlap's not gonna kill us.
Yes, I agree.
Little die, Ray. Come back, please. Come back, please. Negative on your stent. Okay, little die, Ray. Okay, go ahead.
Good.
Perfect. Now we're going to walk it out. I'm going to fix the sheet. Okay, now give me a 7.0 balloon, guys.
7060.
7060. Dorado. So now you see there's a little bit of overlap, which is fine. I'm going across the common iliac, and I've come down. And I'm gone across the external. Now I'm going to use a Dorado. If you don't, give me whatever you got, Chief. 7080 is fine too. Okay, you can walk it out.
I think it looks great. Great choice of stent, preserving the ostium. You always have to know, especially the internals, like you said, become important when they have lesions down in the SFA or the CFA, and they are the ones that provide collateral to the profunda. So always respect the internal. And like you said, look on the other side to see what's happening with the other internal, because that's what they provide the pelvic organ. So I know when we do AAAs, we technically sometimes occlude them because we're concerned about type 2 endoleaks. But here, we're not at that stage right now. So we try to preserve the internal when we have to. So great thought process, PK. So.
Yeah, and over here, Vishal, you can see by the pressure, we still haven't alleviated our pressure. It's better. We've got a waveform. But now we got to go with the balloon and balloon this open. What's going on, Ray?
I think the issue is probably you're in the disease segment of the CFA. The sheath is right there, so that's why you're having this obliteration of the pressure.
No, I put me on coronary, Ray. I want to show you guys. I mean, you can load it. So I want to just show you. Look at my self-expanding stent. Let me go AP here.
Yeah, there's a
look at my stent here. Look at the lesions. You see that? That's got to be ballooned. So once you balloon it, I'm assuming your lesions are gonna your stuff's gonna go away. And I think Ray, you want to go to room 4? So I'm gonna have Ray go to room 4. I think they're ready, right? I know, but they're ready. Well, obviously. So what I want to do is go across right here. Go up slowly. What's up, Chief? You starting? Okay. So Ray can stay around. As the audience can see, like all interventional cardiologists, we always juggle. And you can see here we've got juggling multiple rooms. So, and again, look, it's a total iliac, multiple accesses, PK messing around with fluoro, and we're still done. It's an hour and 15 minutes, you know? So again, guys, this is a gradient thing. No reason to go crazy. Gradient, that's all you're looking at, gradient, right? So right now, no heart rate shift, nothing. He's going slowly, he's at 2, 3, that's plenty. I'm happy there. I'm happy there. I'm happy, okay, down. It's a gradient thing. It's a gradient thing, okay? Pressure dropped. Okay, pressure's dropping.
Just stable.
And coming back. Okay.
He just probably was asleep, so he kicked. So.
Okay. Show me above.
Back up. Nice and good.
Show me the wire.
Okay. Center.
Walk. Okay, wire's fine.
Okay. Where? The leg, the foot, or by here?
Yeah, that's fine.
Foot.
Okay, go. Walk back. Okay, go. Walk back a little bit. Go up now.
And that's where your real lesion was.
Well, you know, we're just being very careful. You know, we've got this really calcified iliac. We've got a patient who's, you know, ill. You know, we're trying to just expand everything down. You know, just go to nominal slowly. What are you up now? 2, 3, 4.
Beautiful.
4 is fine. That's it. Down. Heart rate went down, which we expected. Okay, Vincente, hang on. Hold on. Always give the heart rate a chance to recover, guys. And then we're going to go in again. Okay, right there. Go up again. We're just going to go to 2, 3, or 4.
Yeah, it's a good expansion with the balloon.
3.
So always a good choice of balloon.
Down.
Trying to keep it around 7 or 8.
Yeah, you know, you just want to get rid of gradients. That's what I want people to understand. You know, you want to get rid of gradients. You know, the pressure came right back up. But what we'll do now is what I want to do is I want to use this balloon as my rail, and then try to get this in. Obviously, I'm not doing it, so I'm gonna have you just go up with the balloon slightly to like 2 or 3.
And probably track it over it and to see.
Yeah, you just want to go up with the balloon slowly, and then as it separates from the stent, you know, try to enter the stent, but it's not allowing me. Down with the balloon now. There you go.
Very nice,
You
beautiful.
see that? So that's an important little trick for everybody to know. Now I have access into the stent if I have a perforation, right? So that's the thing. So now I'm going to have him just walk it out, or advance the balloon. Let me advance the balloon slightly. We can do the same thing, right? Just advance the balloon slightly. Just come straight over the balloon. Advance the balloon slightly, straight over the balloon. Now we're in the common iliac, which I'm very happy with. Now we're going to walk this out now. So now I have absolute control of this vessel, right? So now I have absolute control. My patient is stable. My nurse's heart rate is good. And now I'm going to go ahead and take a picture. DSA guys, my pressure gradients are beautiful, as you guys can see.
Beautiful.
Now what the only thing I have to do now is switch transducers. Flush forward, Ray.
I think the PP team needs to kick in soon.
Okay, good. Let it go. Now I'm doing right and left pressure gradients. See that? So remember, you want to do right and left pressure gradients. You want to do above and below pressure gradients. So my right common iliac or my right common and my left are good. Now before I do something, what I'm going to do is I'm going to inject from the opposite. I'm going to inject from above. No move, sir. I know you're feeling weird. It's normal. Excellent. Come forward. Good. So now what I'm going to do is I'm going to talk to the patient, sir. I want you to take a deep breath in. Deep breath in. Okay, that's fine. No, above.
Very nice. The ostium looks beautiful.
Right? Ostium looks good. Good flow. No extrav. Now the important thing now is to see where my gradient is on the opposite leg, right? In order to heal the wound, you want to get rid of the gradients, right? So what I'm going to do now is I'm going to go to coronary again for teaching purposes. We normally wouldn't do all this, but what we're going to do is we're going to go to coronary, and we're going to mag up, and we're just going to walk everything out slowly. Okay? So I just want everything. Let's zero the pressures, guys. Hold on. Let's zero everything. Okay? Zero everything. Good. Okay, we got both zeroed. Now we're going to go up. Okay, so we're identical pressures. Okay, everybody see that? So now we're just going to walk this back slowly. And then as I come back, I'm going to look for any drops. So no drop there. Agreed? Come down. So I'm going to walk a little bit more. No drop. All the way to here. No drop. Now, I'm not going to, no drop. So what I'm going to do now is I'm going to have Ray shoot through the sheath. This is when you can catch perforations in the external iliac. It's from below above rather than above below because you have no competitive flow. DSA, please. So Ray's going to take a picture here. So obviously Ray didn't eat breakfast, so I want everybody to forgive him.
Ray,
Okay.
what happened to that twitch of bicep
ready?
you just lost?
Right.
Push.
There.
Good job.
So he had
Ray.
some breakfast, and Liz gave him a little IV, and now he's feeling better. And you can see here, guys, it's very important that when you see now what you're looking for is any sort of extravasation. You've got no extravasation, and beyond that, very happily, I know Sandeep is very happy. He's a big fan of the hypogastrics for reasons I won't go into. You see that the hypogastric is patent. Now, you could say, well, Prakash, why is it not as patent as before? Because now you have competitive flow. Flow is flowing down your external into the foot, so naturally, you're going to have less filling of the hypo, and what you have to do is you have to go into the aortic picture to see it, and now you'll see that your hypo is gone. It looks like we lost it. We don't know. We may come back, it may not.
It's right there.
It's coming back. Yeah, oh, it's posterior. You're right,
It's just
Vishal.
turning its
Yeah,
posterior,
good
the
pickup.
angulation.
It's a posterior hypogastric.
Because
So
you're
now,
slightly
as far
elevated.
as I'm concerned, I am done. But I am being a paranoid individual that I am. What I'm going to do is I'm going to check for any gradients on the right side because I don't want to keep working on this over and over again. Flush forward, Chief. So we're just going to go ahead and zero both again. zero both again, please. So, because remember, just because you fixed one end doesn't mean you fixed the other end. You got to make sure that you get both, right? Because you're in here right now, you're done, so now you've got no gradient. And again, I'm going to do what I did before. I'm just going to pull this back now, right? I'm going to come all the way. Sorry, sir. 1 second.
Looks good.
There's a little bit of a gradient, right?
Yeah, but
Not much, but a little drop in pressure, which is interesting. Is he okay, Liz? Nope, it's coming back. It's just responding. So I think what we'll do is we'll do a runoff from above, okay?
There is a disease in SFA.
There is a bilateral disease in
yeah,
us.
there might be some
Yeah,
external
there's a-
iliac disease, but
Subtotal on the left and
There's subtotal on the left. I didn't realize that. Okay.
and then
So, well, listen, at least we know what we
Yeah.
got to fix. Ready? Inject. So there's his diseased SFA, which is not really diseased. But again, remember, he has an ulcer, so we have to watch. And then we'll do the below knee. Ready? Pressure's dropped. So he's got 2 vessel below knee.
nice.
So pressure's going up and down. I think he's just a little tired, and he's, we know we don't have an issue, but we'll repeat an ultrasound. I mean, an angio before we get him off the table. So I'm just going to do a last picture here for everyone to see what's going on, and then we'll be done. So, yep. So final picture before we remove the wires. I just want to show everybody. So we're going to go up a little bit higher. Ready? From above only. Oh. So yeah, we can inject both sides then. That's a good idea.
Okay.
Ready?
Yeah.
So we've got both accesses. We're going to inject through both accesses. That was not even worth the dye we spent, but we'll do it from above. Okay. Okay. Oh.
You want 1020?
Yeah, do a 1020 to 1100. Come forward, Ray. Mm-hmm.
1 second.
Good. All right. Fantastic. Okay.
Beautiful.
So while we get everything out, I'm going to just recap with everyone checking ACT, guys. So I mean, we did a lot of demonstration here. We talked
Let's
about
put the
access
sheet here.
points on how to get into the iliacs. In this particular case, we had a CT angiogram that showed a occluded left common iliac into the external and a severely stenotic calcified right common iliac. So what we decided to do at this stage, guys, we should probably post-dilate the right side. Oh no, right? It looks good, right? You went up to
Looks
12
good.
atmospheres. Then I think we're done. So I think as you can see, what we decided to do was get 3 access points because our goal was to cross and to treat from below. So the third access point was a visualization. As you saw during the case, we visualized multiple things. So we tried to demonstrate fluoroscopic guided access, was not as successful, and our colleague, Dr. Singla, showed off and got the ultrasound guided access. So now, once the access was in, you saw the methodical approach of crossing. Dr. Kapoor talked about 014 wires and escalating up to an 035, and then we demonstrated that beautifully. Crossing, balloon, we discussed the choice of covered stents versus self-expanding versus balloon expandable, covered all the way down, and now we have preserved flow into the foot. He has a distal SFA lesion for which what we're going to do is we're going to go up and over at another date and fix it. Right now his rest pain should resolve tonight, and his wound should start healing. We'll follow him closely with our wound experts and see how he does. So thanks again, everyone. And Vishal, on behalf of our team, I'll sign off here and let you do the final sign off. Thanks again.
Thank you, PK. Great job, Sandeep and Ray. Thank you, everyone, for joining us for this live case from Mount Sinai, New York today. For viewing our archive section cases and the cases from today, it'll be available at ccslivecases.org. Please log in to review our cases. And like I said, you can send us comments, questions, and concerns, and we'll be more than happy to answer. For our next live case, please tune in on July 25th at 8 o'clock Eastern Standard Time. Till then, have a great week and a month and a happy July 4th. Thank you.